in a minute. Okay, friends, welcome to this episode of Weight Loss Winformation, and it is a first when I tell you we have never had a bariatric surgeon on the podcast, and we've got over 230 episodes. So in this episode, we're going to talk with Dr. J. George. And to be honest, I've never had the desire to have a bariatric surgeon on the podcast until I talked with Dr. J. George because he has a little bit of a mindset that goes beyond what I hear from the majority of bariatric surgeons that I've worked with in the last 20 years. So I'm going to let you introduce yourself, kind of tell us your journey into bariatric medicine and how you ended up in our neck of the woods.
Absolutely. Well, thanks for having me, Connie. It's a real pleasure to be here. So yeah, I have probably one of the most unconventional routes that you'll hear from someone that's in my shoes.
Okay.
Yeah, I graduated high school when I was 15 years old.
Wow.
I had a full ride ROTC scholarship to Texas A&M.
Go Aggies!
Um,
Did you go there?
yeah, yeah.
That's where I got my PhD.
Are you serious? College
I
Station?
am.
All
Yeah.
right.
Yeah. Their
Well,
team's doing well this year.
I didn't graduate. I actually flunked out, didn't make my GPA, lost my scholarship.
Well done.
Yeah, enlisted in the military. So I was an active duty Navy corpsman with the Marines for 6 years.
Wow.
Um, and yep, deployed to Iraq in 2003, got out in 2004, worked as a paramedic, civilian paramedic, did my pre-med, went to med school, and then did 9 years of post-grad between residency and 3 years of research and my fellowship. So
Wow.
I've been a surgery attending since 2017, so 8 years. And I was in private practice in Chicago for many years. My wife is a colorectal surgeon, so
Huh.
I went up to Chicago for practice,
Yeah.
and now I'm in Georgia.
Okay, so let me get this straight. You fail out of undergrad, and now you're a surgeon, which means either you got very dedicated, because surgeons are top of the class.
Yeah, yeah. You know, I think we all make mistakes, and sometimes we learn from them, sometimes we don't.
Hmm.
Um, I all I can say is that I made a lot of mistakes when I was younger. I still make mistakes now, but probably a combination of immaturity, not being ready for things, not taking things seriously enough. It took me a while to get my act together, for sure.
You and me both. Let me tell you. Um, I graduated from my undergraduate with a 2 point, I don't know, maybe 2.78. Not stellar, not PhD material. So I dig where you're coming from. Yeah, very good. Do you know Charlie Proctor? Dr.
Sounds
Proctor?
very familiar. Yeah,
Yeah, he's here in Atlanta. He has a similar story to yours too. It's like, God, you're so young. You want to get something out of your system a little bit.
yeah. Well,
But
I
you
got
are
it out
where
of my system, that's for sure.
you were good. Thank God. So you got to be where you were meant to be, and you were in the Chicago area,
Yeah, yeah, for about
but you're not
seven, eight
from the
years.
Chicago area.
No, I'm originally from what some people jokingly call tree hugger land. So from the Pacific Northwest. My family's still out there in Oregon, Washington area. So
Okay. So tree
yeah,
hugger to down home Midwest kind of guy
yep.
to, wow, we're in the South now.
Yeah,
Do you like it?
we love it here. We love it here. We needed a much more laid back um, place to have a family and raise our daughter. So
Mm,
Chicago was just getting too crazy for us, to be honest.
yeah. Yeah. We raised our kids mostly well, we're from Iowa, went to Texas, came to Georgia. So our kids were mostly school age in Augusta when we lived in
Yeah.
Augusta. I thought it was a wonderful place to raise kids. I really enjoyed it.
Yeah, we're super happy down here. Super happy.
Yeah. Yeah, that's crazy. Okay, so how and when did you get into the bariatric part of medicine in your career?
Yeah, absolutely. To become a bariatric surgeon, you need to do a general surgery residency, which is 5 years. Mine was a little longer because I did research and things like that. But long story short, when you're a general surgery resident, it's like when you're in high school, you're trying to figure out what to do with your life. Some people just graduate residency and become general surgeons. Some people do fellowships. And I probably picked at the time bariatric surgery for a selfish and a selfless reason. Um, the selfish reason is because to be a good bariatric surgeon, technically you have to be really good. Everything's minimally invasive. You have to be an excellent physician, really know your anatomy, know your physiology, and take care of the whole person. And then also technically you have to be really good. So I wanted to be at the top of my game. And that's one of the reasons I picked the specialty from a selfish purpose. But honestly, the big thing that pushed me into bariatric surgery is um, seeing how incredibly helpful this all is for people. Um,
Yes.
I mean, the near immediacy of results, dramatically changing people's lives for the better. I mean, that's why we become physicians and that's why we become surgeons, right? Is to help people.
Mhm.
But instead of having someone on chronic blood pressure or diabetes medications for a lifetime, we can really like make a huge dent and move the needle in ways that you can't do in other areas of medicine. So I think that that is really, really gratifying.
It really is. It's like exhilarating, honestly, to see
Yeah.
people have that opportunity to, like you were talking about, maybe they felt like they made mistakes or to get a redo at
I believe in
healthier life.
redos, obviously, from my personal journey and from seeing other people with their journeys. It's not a bad thing to need a redo.
I totally agree. And honestly, sometimes I think when you veer off I don't know what kind of path the pearly path is where you grow. It's where you find out, okay, who do I really want to be and which direction do I want to go? And it's up to me now to make the corrections or continue on in the same path. So I think people who have struggled with some questions and some adversity and make good choices have the best of the world, honestly.
Yeah, I agree with you. That's a very profound thing. Um, and I agree with that, that our growth is oftentimes off the path, being outside
It's
of our
very
bubble and our comfort zone. And I tell people that a lot, that it's human nature to want to be inside of our bubble, right? We create a
mhm.
comfort zone for obvious reasons, but whether it's in the gym or whether it's trying to lose weight or whether it's trying to learn a new skill, you don't really grow until you put yourself into some, you get off the path and get outside your comfort zone. So yeah, agree with
Exactly.
that.
Yep. And sometimes that happens by forces outside of our own life, and sometimes we create the mess ourselves. But either way,
Yeah,
I, I appreciate the people who work through and continue on. So now you're in Georgia, and after being in private practice, so what were you doing in private practice? All bariatric
yeah.
surgery, or did you have a medical weight loss arm of that?
Yeah, so I was doing a lot of general surgery, but then I also I started medical weight loss with that practice and with the hospitals we were at. And then, of course, we did the bariatric surgery piece. So it was comprehensive weight management, medical and surgical, and then general surgery. Because at the end of the day, whether you need weight management help or you don't, you still might need a hernia fixed or your gallbladder taken out if it's causing problems or things like that. So.
For sure. So in your work well, first of all, did you start back in the time where they were cutting you stem to stern, or were you laparoscopic from the day
Yeah.
go?
So for bariatric surgery, I've always been minimally invasive. I've never in my career done an open bariatric surgery.
It's crazy when I started, and it was in Augusta, and there was you may not have heard of Dr. Engler. They called him Chubby Engler.
Oh no.
Ironically, he was the bariatric surgeon, and when I first started doing this, he was it was all fully open procedures. That's how long I've been doing this. Isn't that crazy? Yeah. So then the lap band came around. Were you in this area of medicine with the lap band?
So I've put in a handful of lap bands in my career, and I've probably taken out over 100 lap bands. So the
Right.
ratio is skewed towards pulling them out, and I definitely don't put it lap bands in anymore. So
I know. Yeah. It kind of scares me when I hear people say, yeah, I'm going to go have the lap band. I'm like, no, probably you're not. But that's between you and your doctor.
there,
So when,
there are some surgeons that obviously still a handful of surgeons, including my old partner in Chicago, that still do lap bands. But
yeah,
I think that yeah, the data is pretty convincing. I think only about 20% of people that get a lap band don't have a complication, meet their goals, and are happy with it. And the other 80% fit into one of those two not really happy buckets. So,
yeah, yeah, yeah. Do you know, did you meet the guy, Vince? Is it Vince?
oh
Do
yeah,
you know? Yeah.
oh yeah, yeah. That's how I did. That's how I kind of kept up to speed on. Like I said, I did a few bands when I was in Chicago against my better
Yeah.
judgment. So,
He's a great guy to sit and talk to. I'm like, really? Can you take this
yeah,
thing off the market and put your money somewhere else a little bit different?
yeah.
Anyway, he's a good guy. So when the lap band no, when the lap band faded away and then the sleeve appeared, there was concern that the sleeve would fall by the way, kind of like the lap band did.
Mhm.
What are your thoughts? Will it go away? Or, I mean, it's like the thing.
Yeah, I mean, 60% currently of bariatric surgeries, around 60% of bariatric surgeries are sleeves right now. It's definitely a relatively convenient, technically easy procedure to do. Um, what some people don't remember is that the sleeve was originally designed as one of two-stage procedure. So Michel Gagnier, a French Canadian, developed a sleeve or a variation of the sleeve back in the late 90s for people with a really high BMI. So we're talking to BMIs of over 60, 70, 80. And so instead of trying to put those people through, let's say, a gastric bypass, the proposal was put them through two-stage procedure, two bariatric surgeries. The sleeve was going to be the first one, so help drop them down, let's
Mhm,
say half of their excess
mhm.
weight, right? Less complications, let's say, less, kind of a safer
Right.
surgery, and then do a bypass or something else to get them across the finish line. So that's originally how it kind of started. And now it's kind of taken off because it's you don't have to do any connections inside. It's pretty straightforward. So I mean, to answer your question, I don't see it falling by the wayside. I see all of these things, all of the surgeries is kind of like a tool in the toolbox. So depending
Right.
on how you line everything up, goals, preferences, et cetera, I think a sleeve will still probably have a role for the foreseeable future.
So is it true that 20% of the people who have the sleeve end up having a revision to the bypass because of acid reflux?
I don't know about 20%. Um, so the statistics show that about 8% of people that don't have reflux before sleeve, that don't have clinically relevant reflux before sleep, will develop some kind of reflux after a sleep. 8%. It's less than 10%.
Okay.
Now, the severity of that reflux they get after sleeve can be on a scale, it can be from real, real mild to, hey, I need medication every day and I'm still miserable. So
Right.
8% is not a very high number. And a lot of them will have mild symptoms. Now, there are other reasons to get reflux after a sleeve. Now, it's obviously a legitimate concern.
Right.
But for example, one of the things that I encounter commonly in our people that we're doing bariatric surgery on is the presence of something called a hiatal hernia. A hiatal
Mhm.
hernia, as I'm sure you know, is a diaphragmatic hernia. It's basically the space where our esophagus comes through the diaphragm, and if it's loose there already, then that can create reflux problems regardless of what surgery you get, whether you get a
Oh,
sleeve or a
really?
bypass.
Okay.
Oh, yeah. And so I will usually, number one, I will talk to people before any type of bariatric surgery and get a sense of, are they having reflux symptoms to start with? Um, I will typically do an endoscopy, put a little camera down for 5 minutes when they're asleep and get a lay of the land, take some pictures to see if they have something like a hiatal hernia, and then we'll fix those hernias if they have them. So I will usually go after something relatively easy, like fixing a hiatal hernia, before I would consider converting them to something else.
Yeah, okay. So they don't necessarily, if they do have acid reflux, they don't necessarily have to have a revision to a bypass
Not
or
necessarily. No,
okay.
not
You check
necessarily.
for like
Yeah.
the hernia first.
Yeah. So I think that 20% is definitely a bit on the high side.
Okay, that's good to know because, you know, I always tell people I'm not the physician, and the physician has information about your whole system. And so, but I just want you to know that sometimes there are issues need to talk to the doctor. You
Yeah.
know,
Yeah. It's a very common topic. It's a legitimate concern. So what's going to happen is that people before their bariatric surgery are going to fall into two basic groups. Either they have pre-existing reflux or they don't. If they have pre-existing reflux, then I kind of risk stratify them based off of, you know, the severity. Are they on medication, or is this very infrequent? We figure out, is there another reason for the reflux, like a hiatal hernia, things like that. Um, if someone already has, like, let's say, moderate to severe symptoms, then I will typically not advocate for a sleeve, because a sleeve
mhm.
is by definition a refluxogenic surgery, right? You're creating a high pressure system by tubularizing the stomach. Um, you know, so I will say, hey, listen, it's just like pros and cons here, and it's one part of the decision making, right? You can't put all of
That's
the
right.
emphasis on that single factor. You're going to look at
Right.
other things, but definitely you don't want to have someone miserable with reflux afterwards. So, we screen people, we look at their clinical symptoms, we look at the anatomy, and then if they fall in that moderate, intermediate to severe category, I'll definitely consider talking to them about not doing a sleeve.
You know, I only hear this from the patient's side, so I don't know if I'm getting the full conversation. But when I hear they told me I could have whichever one I wanted, I kind of want to pull my hair out a little bit. I'm like, well, you know, maybe that's a starting point, but there's other factors to consider. Do
Yeah.
you think there are surgeons like, "I'll give you whatever you want out there?"
Well, I think that definitely it has to be shared decision making, right? And so it's not an emergency surgery. It's not like you're going to die if we don't make a decision right this second. There's a lot of information that goes into it, but ultimately there is a little bit of a factor of personal preference in this.
Mhm,
And it's like life, right? 10% of life is black or white, 90% is gray. So
mhm.
what I do as a weight management expert and bariatric surgeon, I say, this is what the statistics show, this is what the data shows. But I always take a step back very early in the conversation, starting with initial consultation.
Mhm.
And having been married for 10 or 15 years, I just keep my mouth shut, right? And I listen and I
You're such
say,
a wise man.
and I want to hear it from them,
Yeah.
what they're doing this for. I start with very basic questions like, why do you want to lose weight? And what have you
Mhm,
done before, et cetera, et cetera. But ultimately, it's about goals, right?
mhm.
What their goals are their goals realistic, right? Being on the same page about expectations, and then saying, okay, well, if you're in that 90% gray area where either surgery probably is fine for you, then we start fine tuning the selection based off of, performance from the surgery. Are there any other health conditions that we want to address, like diabetes? Have they had prior abdominal surgeries in the past? Do I think that they're going to stay on top of their lab work and their vitamins? Because as we all know, something like a duodenal switch or a bypass requires more follow-up long term on that kind of stuff than a sleeve. So,
Mhm.
but it starts with the person's goals. And no, I don't just tell somebody, hey, whatever you want, we're going to do it, but the preferences are definitely important.
Curious question. When you ask people what their goals are, and when I ask people what their goals are, do they give you a number goal, or health reasons and living reasons primarily.
It depends. It depends on their level of insight, right? Because sometimes I'll ask them, well, why do you want to lose weight? Well, I want to get rid of this belly. Versus someone that says, man, my quality of life is just terrible the last few years, or I don't have the
Mhm,
energy to play with my kids or grandkids, or um, I want to be on this planet longer with my loved ones, or
mhm,
I think my diabetes is getting worse. So,
mhm.
so the type of answer really depends on how much insight they have and whether they're really connecting the dots between the number on the scale and their health or not.
Yeah. You know what I seem to get more than I would like to hear from patients? Because when I do that pre-surgical evaluation, and all of us, to some extent, they're telling us what they want us to hear. To some
Yeah.
extent. Maybe not everybody, but so then it's all the, "I wanna get in better health, I wanna live longer, I wanna be with my grandkids, da, da, da." And then what I find 2 years later is, "But I never reached my goal weight. But I never reached my goal weight." And I'm like, "Oh boy." Now that's a diet mentality and, you know, a whole other area of this weight loss conundrum, right? And
Yeah.
I I really want people to move away from the diet mentality and toward, you know, accepting the things you can't, changing the things you can, and focusing on the goals that they had that were a little more seemingly important at the time, and how that can be a sign they're slipping back into that diet mentality from my
Yeah.
perspective.
Yeah. I think it's good to have goals for sure. And so definitely having an intangible goal like saying, I want to feel better about myself, or I want to have better self-esteem, or I want to be able to participate more with certain activities. Those are a little bit harder to measure than
Correct.
saying it's a clothes size that I want to get back down to, or a number on the scale. I don't. I think it's human nature to want to put something discrete on a goal, like I want to run
Mhm.
a sub 3 hour marathon, or I want to do whatever, right? But
Mhm.
um, it has to be realistic. And it also has to be based off of other criteria.
For
Like,
sure.
for example, sometimes people will ask me, well, what is my ideal body weight? Like, what is the body weight that I should be at for my height? And I will say something like, well, this is what a chart on the internet says, but remember that we're not just doing it for that. I want this to come from here, from you.
Mhm.
So, and I do try to tease out if they have a number, because to your point, if there's a number that they have in their mind, then number one, I want to know what it is. Number two, I
Right.
want to know if it's realistic. And number
Exactly.
three, I want them to verbalize it, because they're going to work harder for their goals than a number that I tell them the chart on the internet says.
Right. Right. Do you ever tell them straightforward? Because I like to do the math with them. I'll say, "Did Dr. George go over what you can reasonably expect to lose based on da da da, 60 to 65% with the sleeve and da da da." And
Yeah.
there are some doctors who are so good at it and some who don't seem to bring it up at all, because I want people to have a realistic expectation. If they think they're going to get down to 182 pounds and the math says you're only going to get down to 245, I want them to know, because I don't want them to think they have completely failed, and just to say, okay, let's adjust expectations here because based on these numbers.
Yeah, I think so. I do. And so what I do is kind of similar to what you do, Connie, which is that I use my YouTube channel as my platform, and I have
Smart,
hundreds of hours of content on there. So what I do is
smart.
for my initial consult patients, I say, hey, listen, I want you to come to our support group so you can talk to other people that have been through this process. You're going to do everything that insurance requires, dietitian, psychology, et cetera, et cetera. But then I also would like for you to spend the next few months while you're doing these requirements watching my videos. I have videos on the surgeries. What's the difference? How to pick one. I interview patients. I interview dietitians. And then when you come back in a few months, you've got everything checked off. you and I can have a high level conversation, and you can say, "Hey, Dr. George, I met someone that had a sleeve at the support group the other day, and I have a question about this," or, "Hey, I watched your YouTube channel on a bypass, and I have a question about that," and then we can go a little bit more about the expectations and this and that, and
Yes.
make a mutual decision.
So how did you okay, so this is where I see you as more advanced than so many of the other surgeons that I worked with. I mean, a lot of programs will have the requisite, welcome to the program videos, and here's this surgery and that surgery. They don't have hundreds of free informative videos out there. Where did that come from with you?
I have a passion for education and have a passion
Mhm.
for helping people, not just with their short-term goals, but long-term goals, right? We have all seen people do the yo-yo thing, whether it's by themselves or with meds or even with bariatric surgery. And
Mhm.
if they are going to invest this amount of time, energy, money, and we are going to invest this time, energy, and money, let's do it right.
Absolutely. So that means you've taken a lot of your own time to create those. And to me, that is an indication of somebody who values the whole person and wants them to know as much as they possibly can heading into the process.
Yeah, absolutely.
So I shared with you that I've had some surgeons who will blatantly say, "I don't understand the need for psychological evaluation," or I have no interest in the kind of work that you're doing to me, but you're clearly not that person. So where did your passion for this is a whole person. Yes, they need exercise. Yes, they need to know what to eat. Yes, they need the surgery and the person who knows how to put the parts together. But they also need somebody to help them work through the psychological struggles.
Yeah. I mean, the psychological piece is I mean, it's just a huge, huge, huge piece of it. I think that a lot of us have an idea of what we need to do. It's putting it into practice that is so
Mhm.
much tougher. And I see this every day, and I know you do too, where you have people with a reasonable amount of insight and intellect that just there's so many barriers that they don't even see in their lives, and they don't know how to either prioritize their health or to put the things that they already know what they need to do into practice in a
Mhm.
sustainable way. So,
Mhm.
um, that's why for my other company, for Lean Dreams, I have three master's level or above psychologists that focus on cognitive
Nice.
behavioral therapy because yeah,
Nice.
the idea is not to deem whether someone is crazy or not crazy. The idea is to help people ongoing wise, right? Like not just rubber stamp them, but to say, okay, hey, listen, like we need to continue working on this. This is an ongoing process, and it's a complicated problem. It's a complicated answer that I'm going to give you. But the other thing that I see is um, one of the biggest reasons I see people go back with their weight, whether it's with meds or bariatric surgery, is stress. It's life stressors, right? There's
Mhm.
always
Right.
a family member that gets sick, a health problem, a bill to pay, a fire to put out. And I see this all the time. If we could support our people long term, whether it's surgery or not surgery, and say, hey, here's a community, here are resources for you so
Yep.
that you don't go off the deep end every single time a stressor happens, then we're not going to be wasting our energy because it's such an inefficient process where we're being reactive instead of proactive with problems, including
Yeah.
psychological ones.
Yeah, I so agree with you. And research has been very clear. And when you ask people what happened that you returned to some of the older habits, it's always stress in one shape of that word or another. Life happened, but it's always stress. And so what that tells me is people are ill equipped with really good stress management skills. Um, and so somebody needs to be equipping them in this process, or we're kind of shortchanging them and sending them out to the world of wolves and expecting them now that you have a smaller stomach that you're going to behave differently. So when I started, and I come from an alcohol and drug recovery education field, and I know when I went through my own treatment at a very young age, they had a program in place that lasted a full year, and it was a small group. And that's where you learned what do you do instead of turn into a pain medication? Or what do you do instead of turning to your drug of choice or drink or whatever it happens to be? And I thought, where is this for our patients? Where is this for our patients? And that was the first step in why I created those videos. I'm like, I felt so unethical just checking off the boxes. And I thought, oh man, I'm sending you out to the wolves. So the least I felt I could do was to create the mind prep videos. Here's some information you might want to think about as you get ready for this. And here's some stuff that you might encounter after you've had the surgery. So that was the start. And then for the last 20 years, I've just built upon that to build that program. So there's a wonderful, and there are more out there now. There's Berry Nation, there's my bariatric care program. There are several different ones. The challenge in, like, when you're in private practice, you can make that decision. Yeah, I want to incorporate this and use it for all my past, present, and future patients. You know, it's a support group. There's education up the wazoo. But you get a big medical conglomerate with 150 layers of needing to get a yes. It's a tough thing to do.
Yeah, absolutely. I mean, it depends on the system you're in. It definitely takes more signatures and more effort, but I think that if you can figure out a way to frame the proposal in a way that everyone sees as a benefit to our patients, um, there's different ways to navigating bureaucracy, obviously. So, for example, with the system that I'm in now, and I'm relatively new, I've been here less than a year. Part of it is, getting a consensus among, let's say, some of the other bariatric surgeons that work for this system, and getting everyone else to kind of see some value in it, or let's say buy
Mhm.
into it. So that way, when we make a proposal to kind of to the higher ups, that they say, hey, listen, they already have a united front, they've already done their homework, and they're approaching this as a group. So that's still not 100% successful, but it probably increases the chances.
Yeah, and I would think, and I understand corporations have a financial structure and there are certain things that have to be met. And so an expenditure here or there may not fit into that overall plan. But if you think about, like you said, longer term success, longer term positive benefits over sleeve them and leave them, as they say, which is a
Yeah.
horrible thing, right? Um, there would be a lot less. I don't know if the correct terminology is recidivism, but sounds like they're going back to jail. But a lot less struggle with regain if there were the community and the things that the research says are needed.
Yeah, I think data is important. So we've published on this, and we presented this actually at the American College of Surgeons in San Diego a year or two ago, looking at my own data over about 5 years when I was in practice in Chicago. And what we looked at was the frequency of follow-up visits post-operatively for 1, 2, and 3 years out from bariatric surgery,
Nice.
and comparing outcomes, meaning total body weight loss and weight regain, compared to people that didn't have as close a follow-up for 1, 2, and 3 years out. And we showed that there was a difference, a positive difference in people that followed up more closely. Now, it didn't look at the psychological piece per se, because you and I both know that it's really tough to get someone in
Yes.
for close follow-up psychologically afterwards. But this was just follow-up with myself or someone in
Mhm.
my office. So number one, I think the data is important. So if you're going to approach a hospital system, they need to not only see that the outcomes are better, but also you need to go one step further and show them the difference with the bottom line, right?
Mhm.
So whether
Mhm.
it's an insurer or something like that, and that's easy to talk about, it's hard to do.
For sure.
Um, the other piece of this is managing expectations for
Mhm.
everybody, patients, referring doctors, ourselves. And what I mean by that is, um, there there could be a little bit of weight regain after bariatric surgery, right? Like
Correct.
when you look at the curve, right? Like there's a drop off, there's a plateau, and there could be a little bit of regain. Now,
Absolutely.
now you don't want that to, be more than about 10% of, above baseline,
Right.
but letting people know it's okay to have a little bit of fluctuation there as long as
Absolutely.
it's just a little bit is it's
Mhm.
okay.
Mhm.
So I think setting that expectation, right? Because let's face it, let's think about other chronic diseases, right? I see obesity as a chronic disease model. So let's
Mhm.
look at diabetes. How do you measure diabetes? Whether it's a fasting insulin level or it's an A1C or whatever, right? Yes, I want it less than 6.5. Yes, I want it close to 6 as possible. But there might be a little bit of variability. And so as long as we're having that conversation with people and saying, hey, listen, like we're also going to be scoring you, like you were saying earlier about number on the scale, right? Like with our goals, as long as we are having a conversation about someone's health, self-esteem, impact on pre-existing comorbidities and other things, we shouldn't define success just by, oh, hey, I had a little bit of regain afterwards. So
Mhm. Exactly, and I think that's really, really important for everybody on the multidisciplinary team to educate patients about. It's like, you know, it's typical to have a little bit of a regain, but I think at the psychology jumps in there because all of a sudden those old, "Oh my god, I'm a loser, I'm a,"
mm,
how am I ever gonna do this? All those kinds of things creep back in, and that's why that support from that my dog just wants to play, I don't know what. Um, all that kind of negative thinking creeps back in, and to me, that's one of the most dangerous, self-harming things that patients do. Is that critical self-talk and the self-esteem stuff because they've been battered, a lot of them,
yeah.
for their weight and picked on.
Yeah, they need to have access to ongoing support. I always tell my people that once you start with me, you have access to me the rest of your life.
I love
Uh,
that.
if you decide that you're going to move somewhere else, let me know in advance, and I will pick up the phone and I will help you find a program close to where you're living at so you can get plugged in because this is a lifelong thing. You go to the dentist every 6 months or every year, go to your primary care doctor yourself, and if you have bariatric surgery, I am a firm proponent. You should be seeing a bariatric surgeon at least annually, even if you have a sleeve bypass, whatever. I also
Uh-huh.
tell people that this is a shame free, blame free, guilt free zone. You walk in here with the guilt and shame and blame of 10 people already.
Yep.
If you're struggling either before or afterwards, let's say you have a little weight regain and you're thinking to yourself, oh, Dr. George is going to be beating me up, so I'm not going to go in. No, don't think that. Like, I'm not going to judge
Yes.
you. You come in because that's actually when you need help. So,
Exactly.
so put that aside, come in, we're going to support you however we can. So we try to set that tone for people, but still, you're right, people are still going to beat themselves up.
And, trying to help people understand too that regain can be about many, many different factors. A lot of people have PCOS or they have, you know, are taking medications that promote weight gain and they need those medicines for other issues. And so it's kind of trying to help them understand don't beat yourself up about it. Let's look at this rationally.
Give yourself some grace. I always tell people, give yourself some grace.
Yeah.
And it's one of the biggest parts of my practice is not just seeing people getting ready to embark on their weight management journey, but also seeing people that have been in that journey for a while and struggling with the ups and downs. They've had surgery before, they've done meds before, whatever, and helping them sort of come to a more balanced position mentally with overcoming the negativity and starting to become more constructive and more
Mhm.
because yeah, it is destructive and they ultimately I think a lot of people can get in their own way if they're in the
Yeah.
wrong mindset.
Yeah, and that's one of the things that I like to tell people. It's like you know what to do. You know what to do to lose weight, but you're doing this. So if we can identify what your obstacles, maybe it's low self-esteem, maybe it's fear of failure, maybe it's fear of success, identify what's going on and then try to remove that obstacle a little bit at a time so you experience a little bit more success. But a question that I have for you, a couple of them. When people convert from a sleeve to a bypass, some years ago, what I had heard was you're only going to lose that additional 10%. So if you get a sleeve, you lose 60 to 65% of that excess weight. If you have the bypass, you lose 77, 75. So going from one to the other, you're only going to lose that little bit of weight. But now I read recently that you're more likely to lose like 30% of that excess weight you're still carrying. Can you clarify that just for me?
Yeah, absolutely. Well, the first thing that I would say, Connie, is that we have trained ourselves as a specialty to get away from thinking in excess body weight loss. And that's you still see that in some articles and
Yeah.
publications more towards total body weight loss. So a sleeve is 25, about 25 to 30% of total body weight loss. A bypass is 30 to 35. A duodenal switch is about 35 to 40.
Ah, now we're
Um,
changing to okay.
yeah,
I like that
yeah.
better.
So that's kind of how sort of the specialty has moved when it comes to metric measurement. And so medications like semaglutide, tirzepatide are somewhere between 15 to 20% of total body weight loss.
Okay.
But yes, to your point, when you get a bypass after a sleeve, it is not going to give typically the same total body weight loss as if you did it the first time around as a
Right.
primary index operation. And that's one of the reasons why in my practice, because I have a heavy focus in what we call revisional surgery. If I have a sleeve, that needs revisional surgery, it's going to be one of two reasons, right? Either because they're having some kind of issue like reflux, like we talked about
Right.
earlier, in which case I
Right.
would convert them to a bypass because that is going to more than likely take care of the reflux problems, or we're looking at revision because they need to lose weight. Um, and once I've put them through their paces and they've been with me for at least 6 months, I actually make people that have had prior bariatric surgery work harder than people that haven't. Then I will usually, surgically speaking, consider doing a duodenal switch on them, which is
Mhm.
sort of basically a longer hypoabsorptive length of bowel, which means that they absorb less calories. And the data comparing sleeve to bypass versus a sleeve to a duodenal switch shows that a DS is superior if you're doing it for weight loss as a second surgery. So,
Right. Well, let me ask you this. So this is what I ask people when they come in and they're having a psych eval for a regain. You know, finding out what it's about, if they're doing what they're supposed to do, but this god awful uh, reflux or what's going on there.
mhm,
So if a person is basically saying, I didn't change anything, I didn't change what I ate, I tell them a story because I'm a little bit of a, I'm going to hug you and I'm going to kick you in the rear at the same time. So
yeah,
here's the story I tell them. And I think I heard you say you make it a little more difficult for them to have a revision. So do I.
100%. Yeah.
And I think that's fair if they're not doing what they're supposed to be doing. So I say, if you have a kid and they come to you and they say, I want to go to college, you're like, oh, I'm all for it. I want you to go to college. Great idea. Well, dad, mom, you're going to have to pay for this college. Ooh, that's going to be tough. But, it's important. We're going to figure it out. So the kid goes to school, does great the first year, year and a half. But by the end of the second year, they're kind of not minding their priorities as far as education goes. And by the end of the second year, they fail out. Okay. So they come back 3 years later. Mom, dad, I want to go to college. Oh, that is great. It would be great. You go finish that out. That will support you all the way. Well, I'm going to need you to help me financially. At that point, I'd be saying, that's not happening.
Mm.
You went the first time. If you go to school and you do great, then I'll think about helping you pay back those loans. And I say to people, this is in essence what you're asking the insurance companies to do. You gave me the money, I blew it. Now I want you to pay for it again. And I don't know if that sounds too harsh or I'm like, It's not that you can't or shouldn't have a surgery, but before you're approved for that surgery, let's see you pull some of your own weight. Let's set a goal to lose some weight. Let's set a goal for you to turn your food log into the dietitian. Let's see what kind of exercise you're doing.
Yeah. Yeah, I mean, we've been back and forth as a specialty about the preoperative requirements and whether they make a difference in postoperative outcomes or whether they're just another barrier. Um, so I think that's a definitely a discussion in and of itself. When it comes to the role of revisional surgery and doing a second surgery, as I mentioned, the sleeve was originally designed to be one of two stages. Some people just even for bypass, they have too much weight to lose to just put it on a bypass. So
Right.
if I document that, if I have the conversation with a patient that has a BMI
Yes,
of 60, 70, 80, and I show the insurance company, so we're all on the same page. Hey, listen, this is the plan. We're gonna do a sleeve, right? And then once you've maxed out the performance on that, then we'll consider doing it. If you get across the finish line with a sleeve, then we won't have to. That's kind of a special circumstance. But we want to learn from our mistakes, right? We all make mistakes. To err is human. We all know that, and we all know that sometimes we squander, or let's say we don't maximize a gift that is given to us. My personal story speaks volumes about that, right?
yeah,
So the question is have you learned from that, and are you going to repeat the same mistake, or are you going to do things differently?
right.
So, like we talked about earlier in the conversation, I'm all about giving people a second chance. The question
Absolutely.
is are we going to repeat the same mistake or not? So yeah, I do ask that people, because most of the people that come in that have some kind of weight issue after an initial bariatric surgery, I'd say the vast majority of them have kind of fallen off the wagon a little bit.
Hmm.
I mean, I just had a patient the other day who is 15 years out from a sleeve, and she already knew what was happening. She was like, "Yes, I maintained." Actually, she had a bypass. She was about 15 years out from a bypass, and 4 or 5 years maintained her weight. And then she got a job where she was sedentary. She was in an office. She started snacking, and then she started socially drinking alcohol, and it just kept going and going and going. And so at the end of the conversation, she's like, "Well, what kind of surgery can we do? Like a revisional surgery?" I'm like, "Whoa, hang on, we're on first base here. Like,
Yes,
you just got done telling me that that a lot of these things probably need to be addressed in order to get you back on track. So let's work on that first before we start thinking about going back to the operating room."
for sure. I love that. I appreciate that. Is that a consensus, do you think, across programs? Like, people want to help people become more adept at using the tool that they already have? Or do you think a lot of places are just like, yeah, sure, let's do another surgery?
Well, I think that anybody that does revisional surgery, that specializes in revisional bariatric surgery, most of those surgeons are going to think twice before just going out and offering a surgery because the risk profile is high. I mean,
Yeah,
the
yeah,
risk of having a major complication after a first time around bypass is about 0.7%. So it's pretty low.
yeah,
Zero point 0.4 to 0.7%. Now, when you do bypass after a sleeve, or you do a duodenal switch after a sleeve, when you're going back into someone's abdomen, they have scar tissue and something else is going on, right? Like that risk increases. Now it's still very low single digits, so I don't want to scare
yeah,
anybody out of revisional
right.
surgery and say that the risk is high, but it's higher. So, and again, what's the big picture here? We want people to be
Mhm,
successful long term, right? I can do the
mhm,
world's greatest fill in the blank
mhm,
surgery, right? But at
mhm.
the end of the day, if you're not doing these other things and maintaining and finding a sustainable way to do those things,
Right,
it doesn't matter what I do.
right. Right, and we've seen enough, whether it's bariatric surgery or the GLP-1s or any other medications, there's oftentimes a significant regain. So, what do you recommend for your patients in terms of where to go to get the help they need for those issues? Because it's not a surgical problem at that point.
Well, I would argue that anybody that's had a bariatric surgery that's struggling needs to see a bariatric surgeon as part of a comprehensive program. I do.
Without a doubt.
Be- because they're familiar with the anatomy, they're familiar with the
Yeah.
idiosyncrasies of that procedure. And, I always tell people if you had a bariatric surgery, it's like having a $600,000 Ferrari inside, right? So unless you're Wolverine, right, your stomach did not grow back. Um, so let's work with the amazing tool you have.
Mhm.
So those people are best suited with a bariatric surgeon. Now, if you're asking me about people that haven't had a bariatric surgery, I think that they need to see somebody that specializes in chronic weight management. We're not talking about people that dabble in this or that, work weekend shifts doing this. I'm talking about people that
Right.
really specialize in this because it is a very nuanced and very complex problem, right? We're not taking care of people that gain 10 pounds for Christmas.
Right, right, right. So I would absolutely agree that the place to start first is with the bariatric surgeon. But if you recognize that this is related to I don't believe in myself, or I'm really afraid of success, or have you ever heard of the article called? It was written by physicians from Kaiser Permanente. It was called Obesity: Problem, Solution, or Both, and it talks
I
about.
haven't read it.
Oh, it's amazing. But if you recognize that there's maybe a mental health or a psychological or you know, just a chronic self beating up upon, you know, but all their labs are good. You've checked them out anatomically. All that is good.
Yeah.
Do you refer them to therapy? I know you do. I mean, you're
Yeah.
amazing at that, by the way.
Yeah.
Do you
Yeah.
think that's
100%.
common?
Um, I don't know. I can't speak to that. All I can say is that we all know that psychological services are pretty hard to come by,
Yes.
obviously, as a society.
Hmm.
And I think that it's like when we think about the bariatric process, unfortunately, the overwhelming emphasis historically has been to prioritize services on the front end, getting ready
Hmm.
for bariatric surgery, and not really thinking as much about the postoperative stuff. And obviously, as you know, I think that the postoperative part is actually more important. They're both important, but I think the post-op period is really, really important. So to answer your question, yes, if someone is struggling with that piece, I 100% refer them.
Yeah. And are you going to the ASMBS weekend this weekend
I wish I was. No.
in Louisville? I'm going, and um, somehow I always get myself in front of that microphone to talk about the lack of good, solid aftercare use within ASMBS itself. Like it's not focused
No.
on enough. But I really do appreciate that in you. And I want you to know that I've never had a bariatric surgeon refer a patient going on a GLP-1 for an evaluation. And I'm telling you, when you told me you did that, I was like, okay, this guy needs to be in this field.
100%. Thank you.
Because there's so much associated with the disease of obesity, emotional eating, stress eating, food addiction, memories, triggers, all of the things. And so it takes that multidisciplinary team, which I think is the most amazing concept. I'm not sure how well utilized it is in a lot of programs, but I think if it were better utilized, that would be good too.
Yeah, especially with the onset of medical management for obesity. Um, my frank opinion is that most players are doing this wrong. Most programs are doing this wrong. It's too over or too heavily commercialized. Most programs out there, unfortunately, I don't think, and this is a provocative thing to say, I don't think they have people's true interests at heart. I think that is they're commercializing it like they're selling cars or lingerie. And
I feel the
I mean,
same.
I can go out and get a squirrel in my backyard on a GLP. It's going to lose weight, right? I can put my 94-year-old grandmother on a GLP. It's an effective medication, but it is a short-term solution if we don't work on the
Mhm.
other things. And I tell my
Absolutely.
patients, I tell my patients on GLPs all the time, I'm like, listen, you are suppressing a normal physiological response, right? Appetite is true appetite. I'm not talking about from high cortisol levels or poor sleep or whatever, but food noise from emotional pieces. But true appetite is a normal physiological response, like your body saying you're thirsty, you got to go to the bathroom, or you're sleepy. You suppress that iatrogenically, of course. Yes, you're gonna not feel as hungry and you're gonna feel full faster. But what is your game plan when you stop the medication? Because one of two things are going to happen: either you're going to run out of money, or your insurance company is going to stop paying for it, or you're going to reach your goals, you're going to come off the meds, your appetite is going to rise again. And unless you have a game plan to deal with that psychologically and lifestyle wise, your level is going to go through the roof and you're going to have some regain. So
For
my
sure.
job, especially for the medical piece, just like I do for the surgical piece, is to help people think about that 30,000 foot view and help them establish a runway to land on
Love that.
after they come off the meds.
I really do love that, and I can't tell you how much I appreciate that because I understand, and even in this article that I was talking about, the surgeons say, we have an easy out if we want it by saying, "This isn't our field. We weren't taught to deal with the psychological stuff," and I respect that. It's like if I'm a surgeon, I don't want to be a therapist as well. So I absolutely respect that. But what this article shows that these doctors recognized is I don't know how they do the training today, but they were saying, we had no idea the enormous psychological piece surrounding obesity. We thought it was just physiological, and it's a really great article. I'll send it to you. It's pretty fascinating. Of
Thank
course,
you.
I don't understand how to I should, but I don't know if it's good, solid, the research parts of it or not. But the information that they shared, I think, is pretty brilliant. So I will share that with you. But I got to tell you how genuinely impressed I was just with the first time I talked to him. I'm like, this guy doesn't sound like, one of these things is not like the others.
Yeah.
And I have met, I will say, fortunately, like Charlie Proctor in Atlanta is very much that way. There's a guy that we've become good friends with in New Zealand, David Schroeder. He's all about the whole person kind of thing, but it's rare. It's rare, and so when those of us in my position find amazing people in your position who are looking at the bigger picture, it really is acknowledged and honored in the community.
Thank
So
you.
thank you. So do you want to talk about your other program just a little bit so we know what it is?
Sure, absolutely. Yeah. So I have a virtual medical practice online. It's called Lean Dreams. It's a pretty young program. It's about a year and a half old. We cover all 50 states, and kind of
Wow.
yeah, in a nutshell, it's a comprehensive weight management program, right? We're not just a weight loss program, we're a weight management program, which, everything in the words and the terminology, we help people not just lose weight, but develop the skill set to maintain.
That's my
So
that's my
so
whole thing.
we have a multidisciplinary team. We have registered dietitians, personal trainers, psychologists. All of the psychologists focus on cognitive behavioral therapy. We have nurse practitioners, physicians, and when so we have a la carte programs. So let's say someone's already on medications through their insurance, or they're already getting some support, but they don't have, we call them lifestyle coaches, but they're actually psychologists, because you're going to laugh at
Mhm.
this, but if I say psychologist to the regular person in the public, they go running for the hills. So I call
I
them
know,
lifestyle
it's true.
coaches.
True, true, true.
But we can either give them some a la carte support and have them see a dietitian or somebody once a month. We have a very nice holistic program because not everybody wants to put medications in their body. So the holistic program is meeting with all of the high level coaches every month. It's all virtual. So they just basically get on a Zoom call and the personal
So
trainer will
great.
help them figure out routines at home or at the gym, things like that. And then our medication based programs, we do use compounded medications
Mhm.
in select circumstances where we think someone is medically it's indicated, but it is what comes included with medications are the high level coaching. So when you
Ooh.
start a program with us, you don't just get the medication piece, you also get to meet with the coaches on a monthly basis because we want people to understand the big picture. So,
And that's how all bariatric programs should be. Hello.
yeah. So yeah, I mean it's a nascent program. I mean, there's a lot of competition out there, obviously, but ultimately, I just want people to just realize that it's a long-term commitment, and it's going to take a lot of work. Anybody that's coming in that really has significant overweight or obesity, right? It's not a quick fix. So
Mhm.
trying to get people's expectations toward the center is really important. And whether they get help with us or they get help somewhere else, ultimately, if they at least have a little bit of that realization, then I think that
Mhm.
I've done some of my job. So,
Are you familiar with a program called Toward Health? And the guy's
mm-mm.
name is Dr. Tro Kala, I don't know, Kalaygian. I think you guys would have amazing conversations.
Okay.
He's an interesting guy. He's not a surgeon. He what he does is he has the coaches and all of that. But what he does is he has monitors, glucose monitors for everybody, and they monitor their glucose throughout the day. And they also monitor what? I don't know what else they're monitoring, but they've got two things that they are constantly monitoring. And so the staff is seeing these, and they can contact the patient and say, listen, we're noticing this activity, and that typically suggests that you're going to start regaining. So let's look at what you're doing and adjusting. Fascinating, but it's the whole picture thing too.
Remote patient monitoring. Yeah.
Man, yeah, it's like dang, impressive. But they also have the therapists on staff and the coaches and the it's a whole person thing.
I was going to say the technology is pretty awesome. And so we have some of our patients on, Aura rings and things like that that helps
Yeah,
them
yeah,
monitor their sleep quality. But ultimately, yes, the habits, the putting it into practice, learning consistency, education, accountability, all of those things, no tech can replace that, at least not for now. It gives a little bit more information and a little bit more convenience, but you still got to go back to the basics sometimes.
yeah. I came up with something last week, and it's been kind of gnawing at me and gnawing at me. I'm like, what is this thing I'm trying to consolidate for when I go give my TED talk on weight management? And it came to me. I mean, I've always talked about negative self-talk and that sort of thing, but it's like if a person cannot tap into self-compassion and say, "Okay, yeah, I messed up, but I'm gonna get back on," and that's not the worst thing in the world. It doesn't mean I'm a loser and I'm a failure and the names my family called me. So compassion, self-compassion, which is a great and wonderful thing, but you also need the adult component of accountability. So I'm gonna call my next book Compassionability.
Mm, like it.
Yeah, onward we go, right? All the
Mm.
pieces have to come together somehow. But you're great. I love your approach. I love that, and I know from working with your patients that you give them a clear story, and
We
I
try
appreciate
to.
that.
We try to.
Yeah, one last question, which has I mean, you guys do you do the Sadie and the duodenal switch? And
Yeah.
so let's say there's a program in other places, and their options are the sleeve or the bypass. But
hmm
it seems obvious to the multidisciplinary team, this person needs something a little more. But because that place doesn't offer it, do you find that to be unethical a little bit, or is that the wrong categorization of word choice?
Yeah, I probably would characterize it so everyone's got a different skill set and different comfort level. Now, among, you know, medical professionals, psychologists, right, there needs to be an ability to stay with the times, to continue educating ourselves, to be dynamic in our thought process so that we can help people, right? We can't be
Mhm.
stuck in the past. Surgical techniques are not necessarily easy to pick up and learn. So if you trained a certain amount of time frame ago and that's what you're comfortable doing, learning something new can be done 100%, but not everybody does it or has a comfort level for it. So if I'm ever, and I think all surgeons should be like this, ever in a position where you cannot offer a surgical service because it's outside of your skill set or comfort zone, you should have the wherewithal to be honest with yourself and with the patient and say, hey, listen, I think that this is something that you would benefit from going to another center where they offer it.
I do
Um,
too.
there might be a disconnect in the actual thought process before that, though, meaning that someone thinks that converting a sleeve to a bypass is the way to go, and they don't realize that it's probably not as good as doing a DS or duodenal switch on. So if that thought has never entered their mind that there is another option, then that's a different problem.
Well, that just says they've never been to a conference for continuing education, if you ask me. Yeah, it's kind of a pet peeve that I have when, somebody comes to me and they're super morbidly obese, and
Mhm.
the doctor's saying, "Do the sleeve," and I'm like, "Are you aware of that there are other surgeries?"
Well,
And a lot of times
if that person is if the surgeon is saying, well, you know what, your BMI is the point where we're going to consider doing a two-stage operation,
correct. Yes. But if there's not, it's just like, "Oh, yeah, we'll go ahead, we'll do sleeve for you," as if that's the be all and the end all.
right?
Oh, it makes
That's
me, clutch my pearls down here in the South.
that's tough.
Mm. Yeah, anyway. Great, great discussion. So, what kinds of things would you say when a person is considering either medication management or bariatric sleeve? What is something you would say going into this process? Here's something I'd really like you to know, in addition to the
Yeah.
details.
Yeah, absolutely. Well, um, you need to be honest with yourself, I think, about a few things. Number one, um, you know, are you what are the reasons that you're doing this for? So, it's one thing to have goals like, hey, I want to lose 50 pounds or X amount, or I want to do this or that, but why do you want to do that? Like, do you have enough understanding about the why that when the going gets tough, you're going to stick with it because there's always going to be good days and bad days. And the why is I think, a very powerful motivator when the going gets tough. So I think we need to make sure that people are honest with themselves about that. The second thing is, um, definitely do your research, do your homework about whether something is going to help you reach those goals or not. And we all know that on paper, a medication may offer a certain amount of performance, or bariatric surgery may offer a certain amount of performance, but there are some, let's say, logistical considerations that have to be kept, such as, do you have insurance benefits that cover that medication or that surgery? What is
Correct.
your out-of-pocket expense? Et cetera, et cetera. Because at the end of the day, someone's got to pay for this, and
Mhm.
not everybody has benefits. So pick up the phone, call your insurance company, spend 45 minutes listening to elevator music so you can get the lowdown on what exactly is covered and what your out of pocket expenses are, so that that's all part of the informed decision making. Um,
Absolutely.
and then the final piece I would say is are you, again, being honest with yourself, are you in the right place mentally, physically, personally, professionally to commit to yourself to actually say, I'm going to make my health a priority to do this? Because if the answer is no, because you got too much on your plate doing other things, don't waste your time. And don't
Mhm.
waste other people's times embarking on a journey that you're only going to half do, right? If the
Mhm.
answer is yes, now's the time. I'm ready to commit myself. I'm ready to make health a priority. Then go for it. Don't be
Mhm.
afraid. And if you're worried about something, go to most programs have support groups or information sessions.
Correct.
There is no strings attached. Go
Right.
listen to somebody that's been in those shoes. No two stories are the same, but a
That's
lot
right.
of similarities and parallels can be drawn, right? So go talk to somebody that
Uh-huh.
had a sleeve or a bypass or did medications. What did they like? More importantly, what did they not like? Right?
Right.
What would they do differently again? So then some of that anxiety and fear about making that first step can be a little bit alleviated.
Absolutely. Absolutely. So, how do people get in touch with your online program if they want to participate?
Very, very simple. You can go to our website. It's www.lean, Lean, dreams, DREAMS, weightloss.com.
I love that. All right, I'll put that, of course, in the show notes. That's great. I think sounds like a really amazing program.
And our
All right.
entire team is bilingual. So,
Oh,
uh,
that's fabulous too.
yep. So we have a lot of patients that are, that are Spanish speaking primary. So,
Hmm.
yeah, that's another thing that we really try to emphasize support with is the Hispanic community.
I'll tell you what, I have a book here sitting right on my desk. Learn Spanish fast for adult beginners. I took Spanish all through high school. So I'm standing at Disney World a couple weeks ago, and there's a Hispanic family in front of us, and they must have said something to us. And I heard her say, "She doesn't understand what you're saying." I said, "Oh, entiendo un poquito solamente."
And I'm sure they were like, wow, that's awesome.
Yeah, she was like, "Oh, she got the biggest kick out of that." All the other thing I could do is ask her where to go to the bathroom. So
It's a
anyway,
good
thank you
start.
for this. I would love to have you on again so you can answer the controversial questions that I have and that I'm sure other people will send in. I appreciate your perspective because, you know, I wish at those meetings they would put the multidisciplinary disciplines together so I could know what surgeons are thinking. And so you guys could know more of where we're coming from.
Like ASMBS.
Yeah, like ASMBS, where we're integrated health and we get no interaction with the surgeons.
Well, I wish I was going to weekend. It was on my radar, and then I kind of forgot about it. But I would love to see you if you're going to be at the national meeting next year. We definitely need to
Oh,
get
I
together.
will definitely be at the national one next year. I skipped this year, and I can't remember why, but I was there the year before. So yeah, I need some credits, so I'm going this weekend to try to get my continuing ed credits
Yeah.
before the end of the year. Well, thank you so, so, so much. You are a delightful human and doing amazing work in this field. I'm so glad you're in Augusta.
Thanks for having me, Connie.
You're
Appreciate you.
welcome. All right. Talk later.
All right.
Bye.
Bye bye.